Cushing give the first presentation of the day. Kelly is a clinical lecturer in gastroenterology, and she's going to talk about insights into inflammatory bowel disease today.
So first of all, thank you for the invitation to speak. I've been working with the MGI since I came on staff here, and it's been a really rewarding experience, so I'm glad that I get to share some of what we've been working on using the data set. So first off, I don't really have any financial disclosures, just in the terms of transparency. I included data sources that we have access to and committees or organizations that I'm involved in. So I only have 15 minutes to sort of convey what we're working on, and I really bucketed things into about 4 different agenda items. The first is I just want to give you clinical background. So what is inflammatory bowel disease, and why do we feel like it's a great disease to study in precision health? How did we develop our cohort using MGI resources? And then I'll highlight a little bit of just a couple projects that we're working on in terms of underlying genetic risk across IBD and comorbid diseases. And then I'll just end with where we hope to move in the future as we move forward with our program. So talking about inflammatory bowel disease, it's essentially a chronic immune-mediated disease of the GI tract. And so what that means is your immune system is overly active, causing inflammation in the gastrointestinal tract. It affects over 1 million Americans. So while not a prevalent disease, it's neither a rare disease. So it's something that we're seeing increasingly common in patients. It's also becoming increasingly common in actually countries that are becoming westernized, whether that's through industrialization or westernized diet. We're seeing a rise across the world. In terms of the pathogenesis, it's not straightforward. What we know is that it's complex, and it probably involves multiple different factors. One factor that's clearly been associated with inflammatory bowel disease is genetic predisposition. So early on, the studies were twin studies, family cohorts, and they saw higher risk in individuals who had strong family histories of inflammatory bowel disease. That led to GWAS studies, and to date, we have over 180 variants that have been associated with increased susceptibility to develop inflammatory bowel disease. These variants have been very helpful because they've identified parts of the immune system that seem to be overly triggered in inflammatory bowel disease patients, covering both the innate and the adaptive immune systems. And many of the drugs that we have actually came from these studies. The gut microbiome, so we all have really good bacteria in our guts that play a lot of healthy roles in terms of pathogen protection, nutrient metabolism. But when there's changes in the microbiome, that can increase disease risk. And so they are seeing decreases in the number, the diversity, and the richness of microbial species in patients who have inflammatory bowel disease. And there's even some work now looking at therapeutic response as measured by changes in the microbiome. And then finally, the environment. This is a really, really difficult thing to study, as you can imagine. But smoking has been clearly linked to your risk of inflammatory bowel disease. Less so diet, more so diet, but very difficult to differentiate what are the actual ingredients, micronutrients that are actually contributing to your disease risk. And then finally, geography. So latitude seems to actually play a role. So what do we see clinically when patients come in to see us? Well, they can have a lot of different symptoms, but I would say the most common are abdominal pain, diarrhea, they can have significant bleeding, and then we get these more non-specific symptoms, weight loss, fatigue, and then they can even have symptoms that are outside of the GI tract, like joint pains, for example. I've included some images here just to give you some perspective of what these patients are going through. So on the left-hand side, you'll see a normal colon. I don't know how well this is projecting, but basically it has a very nice sort of pale yellowish mucosa with red vascular markings. But as you get into the other subtypes of inflammatory bowel disease, there on the right, ulcerative colitis and Crohn's disease, those are our 2 main types. You can see that there's significant inflammation. There's redness, there's swelling, you've lost the fold marks in the colon, called haustra, and you start to get ulcerations and erosions and breakdown of the mucosa, and that's what leads to pain, bleeding, and diarrhea. So this slide is really just to show you how important precision health actually can be in inflammatory bowel disease. These are all of our classes of therapy, not even all the therapies, just the classes of therapies that we have. So within each class, we can have several drugs. And they all, in some way, target the immune system, whether broadly or more specifically looking at a specific signaling pathway or perhaps class effect. So the problem is we have all these options, but we have no data to tell us how to pick a drug for each patient. We really rely on clinical risk factors, what we know from our epidemiology research, to drive decisions in the clinic. which is not obviously the ideal way to do it. We want to know what's driving your inflammation, and let's target it and get the right drug the first time. So that was what spurred us to say, well, precision health would be great in inflammatory bowel disease. How can we advance research? So when I first came on staff here, talking with my mentors, who include Dr. Spaliotis and Dr. Higgins, one of our IBD experts, we started to ask ourselves, what would be most important when we build a cohort proactively? Well, number one is, obviously, if we're looking at genetic risk factors, genotype data. It's very, very hard as a young faculty member to be able to build a prospective cohort with high quality, large number patients who are contributing full genome data. So having available genotype data, it's cost effective, it's great as a young faculty member. So I was really fortunate to come in a time when MGI was in a period of rapid growth. You had already recruited 50,000 participants. And so this was really an amazing opportunity for me as a faculty member to collaborate with the MGI and advance our research. In terms of clinical data, this is actually, I love that the keynote is on this because this is a really hard topic for us. Extracting data from the EMR in large amounts is difficult because there's things that are very concrete, like age, gender, ethnicity, things like that. But when you look at like more subtle things like drug response, comorbidities, these things are difficult, and sometimes there are biases in the medical record. And so we wanted to say, how can we get the highest quality data? And can we have it be longitudinal? Because one point in time for a given patient, helpful, but not ideal. We really want to know their full disease course, what they've tried, what they've failed, what comorbidities they've had. We want the whole picture of the patient. And then finally, controls. Always wonderful to have controls when you're looking at data. So again, we came to the MGI and said, wow, you have access to all this. Can we work with you to help advance our research? So this is just a snapshot of where we're at in terms of numbers. This is from Freeze 5, and Freeze 6 is coming out. But we have just under 2,000 patients who have a ICD diagnosis of inflammatory bowel disease. That means a clinician has decided they have inflammatory bowel disease, and it's encoded in the EMR. We have two types of IBD, which I told you about, Crohn's disease and ulcerative colitis. And so breaking that down, there's pretty good even distribution across our subtypes. Maybe a little slightly skewed towards Crohn's, but overall really, really great representation of both types. And then you'll see we have one really small category that's IBD unclassified. That just means it's very, very difficult to tell these diseases apart sometimes. And we sort of bucket a group of patients, a small group of patients, into this situation where we can't really tell them for sure which one they have. In terms of phenotype data, we worked with the Data Office for Clinical and Translational Research. So we came up with a code book, things we're really interested in, and have literature to support why we're pulling the data. And they cover all of these different domains. I won't go into detail about them, but I think it's important to know that we're linking the EMR data with the genotype data. So this latter portion, I just want to talk about just some of the initial research projects that we've worked on, and I'm going to focus mostly on IBD and patients who have comorbid disease, meaning they have a second disease of interest in IBD. So before we get to this, let me just tell you a little bit about comorbid disease in IBD. So patients are at high risk for a lot of diseases, whether it's malignancies, infections, metabolic diseases, you name it. There's a wealth of epidemiologic literature to support that. There's probably three sources of why we see that increased risk. The first is the patient themselves. So it's probably a consequence of underlying shared genetics or biology between the diseases that's driving that association. The second is the disease itself. So once this inflammatory cascade starts, it becomes very significant and it can lead to complications. And so things like clots, for example, can happen in our patients when we have a lot of inflammation going on. And then finally, the drug. So immune suppressive drugs are great to reduce the inflammation, but when you start suppressing the immune system, it can have adverse effects because of that. So this is sort of where we started in the literature and what's known about IBD and comorbid disease. And this really gets at that patient concept that I was just telling you about. What we know is that patients often will have diseases outside of the intestine that we consider actually to be part of the spectrum of IBD. We call them extra-intestinal manifestations. So things like inflammation in the bile ducts of the liver, inflammation in the joints, in the sacrum, skin inflammatory diseases, and they actually have overlapping genetic risk with IBD that's been well established. And so I just highlighted a few here that I think are relevant to talk about because I had told you we have a lot of variants that associate with IBD susceptibility risk, and you can see that many of those also contribute to comorbid diseases. And they also happen to be targets of therapy that we use. So for example, the JAK2, we have JAK inhibitors. So This is an FDA-approved therapy for IBD. So it may be patients that have JAK2 mutations with comorbid IBD and PCA might be the right person to start on a JAK inhibitor. And then we've got some that are in clinical trials like TYK2 inhibitors, which we're still learning about, but have shown promise. So this really gets at making a decision based on a biomarker of the patient, understanding they have a genetic mutation might drive shared biology across diseases, and deciding to put them on that class of therapy first. So the interesting thing is, we've always assumed that this all bucket of disease and treatment-related adverse events are separate from the patient. So those are driven by the inflammation, or they're driven by the drug. However, there's been good recent data that in our literature to suggest that there's actually associations that are medication independent, for example. So, for example, rates of cancer seem to occur at higher risk for patients with IBD than non-IBD patients. And that doesn't seem to be driven solely by medications. Definitely medications play a role, but not the only role. So that drove us to say, okay, we have this great data, we should probably start looking and seeing if there is shared genetic overlap or shared biology that might be contributing to some of these things that we've always bucketed into treatment or other related adverse events. So we actually looked at 4 different comorbidities that we really see quite commonly in IBD, and I've listed them here. They include both types of skin cancers, melanoma and non-melanoma. We see a lot of osteoporosis, low bone density, and we see higher rates of C. difficile infection, which is highly morbid for our patients, unfortunately. And so what we really wanted to ask was, beyond the medication effects, are there independent genetic effects that might be explaining part of the associations that we see? And we chose these based on either the literature or our independent testing. We have a separate cohort, which I haven't mentioned here, that's a clinical cohort and includes all patients with IBD at the University of Michigan, in which we can do more clinical outcomes work. So this is a summative table from a couple different papers that we've published, and it's not all inclusive. It really just highlights some that I wanted to talk about today. But basically what we did is we know there's IBD risk variants. They've been well established from large-scale meta-analysis of GWAS summary statistics. So we didn't go reinvent the wheel. We said, okay, let's take the risk variants that we know are well established, and let's test them for effects in these other disease outcomes. And in some situations, we could actually control for medications depending on which data set or access we had available. And so what you'll see is that there did seem to be fairly significant effects for some of our IBD risk variants on these outcomes. So for example, non-melanoma skin cancer and bone density had pretty strong effects. And so here I've included some of the genome-wide significant, those that met genome-wide significance, but also things that were maybe like nominally significant, less than 0.05, but I just think had interesting biology that I wanted to talk to you about today. So I'm going to dive into these just a little bit more. And for reference, this table obviously includes the outcome, the population size of the data set that we were working with, whether it's MGI. We also used the UK Biobank for validation in some of these discovery and replication cohorts, or we used available meta-analysis data through the UK Biobank as well. So coming back to the first part of the table, which was IRF and IRF4 and batch 2, those linked with non-melanoma skin cancer. And just to go back, it was 1.13, 1.14, so 13 to 14% increased risk. What we know about that particular region is that IRF4 actually has been really, really well established to link with non-melanoma skin cancer and their independent GWAS. It's also been linked to how the cancer behaves, so it's more aggressive if you have these mutations. So what we were seeing as an androgenic variant is probably a reflection really of IRF4. We also know that batch 2, which was nominally significant, but also in our sort of top genes, actually interacts with IRF4. So it blocks IRF4 from binding to DNA. And IRF4 is a transcription factor which modulates the interferon signaling system. And so the reason this is interesting is because it suggests that maybe this pathway is important not only in IBD, but also important in non-melanoma skin cancer development. And so this would be something that would be interesting to potentially validate and look into functionally and start to think about maybe this is a therapeutic target across diseases in a novel way, because it's not really currently actively targeted. The second thing that was interesting, this was more nominally significant, but IL-2 signaling in melanoma skin cancer and IBD. The reason this is interesting is from a clinical perspective. Okay, I'll speed up. So IL-2RA basically, as a subunit that mediates IL-2 signaling, high-dose IL-2 therapy is actually used in melanoma skin cancer treatment. It was used predominantly in the 90s, less so now because of adverse effects and more effective drugs, but well-established therapy for melanoma. And actually now we're using IL-2 signaling in clinical trials, small clinical trials for UC. And then finally, NFAT-C1, kind of interesting because it actually is modulated by short-chain fatty acids. which are, we basically deliver them via enema usually, and they provide good, healthy fuel for our colonocytes, have anti-inflammatory effects in the gut, but they also have protective effects on bone density. And then I didn't mention C. diff because we didn't have any shared genetic overlap. So we actually did is we did an MR as well, just because we wanted to see if there were any causal effects for C. difficile infection. And we have publicly available GWAS data, and we did our own meta-analysis of GWAS summary statistics for C. diff. There wasn't a lot out there, maybe 1,100 or so participants in a GWAS, so we got up to about 3,500 when we did it. And what we found is that there is a causal effect of genetically predicted IBD on C. difficile infection, and that risk is actually predominantly driven by ulcerative colitis, genetically predicted ulcerative colitis. Very consistent with what we see in the clinical literature, which is colitis is the main risk factor. So the main point I want to drive home today is that understanding shared disease can help us identify biomarkers that can help us get the right drugs for these patients up front. And so get the right drug, the ideal is hopefully improved efficacy, improved quality of life, reduced side effects, and unnecessary drug exposures. To summarize our future goals, basically we plan to test additional phenotypes. We have many more that are higher risk in IBD patients and that we have availability for additional shared or causal effects. And then we also really want to move into drug response, prediction of drug response. This is sort of an area of like rapid growth in our field, but we still don't have a lot of biomarkers to actually drive decision making, and we hope to expand this as we move forward. So in terms of thank yous, Dr. Spaliotis and Dr. Higgins as my primary mentors, and my other mentorship panel is listed as well. The labs, collaborators, we appreciate Grace's help. And most importantly, obviously, the Michigan Genomics Initiative. There's no way we would have, at least I personally would have had as much growth as an investigator in the first couple of years here without access to the data and collaboration. I would give a particular shout out to Brett, who's been like immediately available for any questions and super helpful to our team. And then the data officer for clinical translational research as well. So thank you.
Questions?
Thank you. Thank you. There was a lot packed into a very concise time. The C. difficile comorbidity, how can you tell whether it's associated with the genotype connected with the primary condition, or the presence of bad bacteria and yeast, which is also connected with the condition, but more indirectly?
Yeah, I mean, well, I think you took a good point, which is like multiple things can predispose you to develop C. diff infection, and there's certainly good literature to suggest that a disrupted microbiome can be important. What we were looking at was really using the Mendelian randomization, which the idea is that you had natural distribution of your alleles at birth, and so it's sort of a natural randomized controlled trial. So what we're saying basically from our data is that if you're genetically predisposed to develop IBD, you also are at increased risk of C. diff. So it might be that there's common mechanisms that contribute to both diseases. We know microbiome is important in IBD as well. So I don't think it's fully deciphered. I think there might be connections there, and that genetics just may be reflecting what's actually happening, at a biological level.
Getting my workout here.
Flag you down. Wonderful talk, thank you. I was very impressed with the evident pathology that you showed on those slides between Crohn's disease. I've never seen that before. And I was just curious, how many times do you do a colonoscopy or something on people and you see that kind of pathology and they don't have any symptoms?
That's a great question. Yeah. So getting at some of the clinical perspective is more often in Crohn's disease as opposed to ulcerative colitis, we can see this discrepancy where somebody says, I feel great, but then we go in and it looks terrible. You also get the opposite, where people don't feel well and you go in and it looks good because there's maybe a secondary GI illness like an irritable bowel going on. So I don't have a number for you, but there's definitely a subset where they feel great and we see bad disease. Those are the hardest patients, honestly, to convince and say, you really need a therapy. I know you don't feel bad, but what's going on inside is increasing your risk of a lot of complications.
Would you hypothesize that the genetic architecture of Crohn's, IBD, all these are similar among patients who don't have any, maybe have been incidentally found to have this kind of imaging or this kind of pathological finding? Or do you think that there's differences in the genetics?
Across different types of inflammatory bowel diseases?
No,
outside-
let's say you have a patient who just feels fine, they don't have stomach ache, anything like that. You do scope and you're like, whoa, this looks like Crohn's.
Yeah.
Do you think that the genetic
I
architecture
see.
for those type of patients?
I don't know. That's an interesting question. Yeah, I mean, you really have to dive into the record to be able to parcel out those patients and study them from a genetic standpoint. I don't know how high the power would be. You know, we have 2,000 patients as a whole. I think if we did that, you'd probably be looking at like 10 or maybe % of the patients. So it would be a really interesting study, and I don't think we know the answer. But yeah, probably maybe in the future as we grow.
Well, thank you, Kelly, for the wonderful talk. I'm curious related to the symptoms. So, some of the risk variants, like in IR4, for instance, more associated with certain symptoms, are not necessarily causal for the disease. So, for example, the incidence of flares, rather than the occurrence of the disease itself.
In terms of what's been studied, you mean?
Yes, in terms of what's been studied, or also in terms of what you have observed.
Oh, yeah, I mean, so if I understand the question correctly, I just want to make sure, it's about what I've observed in terms of if there's an association between genetics and symptomatology independent of pathology. Yeah. I think it just gets back to the fact that we don't even use genetics now. This is all research-based, so we have no idea in the clinical setting who has what genetic risk factor and who doesn't. I mean, in terms of anecdotal response to drugs, even that I would say is hard to say. So I think it's a good question. I just don't have an answer for it.
Thank you.
Another challenge.
I have a pretty date past LA Fitness for you. Halfway through, you were talking about whether associated symptomatology was connected with IBD or with the drug. And there's been investigation of that. And I wonder whether that investigation includes relatives who are not taking a drug or not taking the same drug.
Yeah, I have not seen data to support that, but it would be an interesting study. I mean, all the data that I've seen is from primary individuals as opposed to family cohorts. But we actually do have, I have to dive into our data, but we have available data on family connectedness. And so we could actually dive in and see within family cohorts or groups of members who are siblings, which ones developed comorbidities and which one didn't, and do they share the same, genetic risk, or do they have different genetic risk? Yeah, so that would be interesting if we have the data.
Anybody else? Of course. I can talk. I can talk. So I guess I'm curious, if you could sort of speculate, like, how do you plan on operationalizing like successful drug treatments? Because that sounds like that's what you're doing.
Yeah, I mean, I think we're far away from that, just to be realistic. I think my feeling on what we're doing currently is to start a conversation, to start thinking about actually looking at drugs as decision-making tools in terms of underlying individual risk and how that contributes to a spectrum of disease. Because right now we just bucket things separately, but they might all just be a spectrum of immune dysregulation within a patient. But probably what we need to do before we even get to drug selection realistically is actually look prospectively and say, okay, if you have genotype X or Y, do you respond more significantly to this drug? Let's just say an IL-23 blocker, for example. And then if you really wanted to be rigorous, you would put it into a clinical trial. You would say, okay, if you have this genotype, you're gonna go on X therapy and we're gonna study it in a balanced population. And then if you get that data, you would go to the actual, you would operationalize it, right? In that setting, you would say, okay, we have a commercial test to test your genotype for, let's say, IL-23R, and then we would select based on that. That would be the goal. We're probably very, very far away from that, realistically.
Okay, this is our last question. We have to move on, unfortunately.
Should be on, but.
Oh, I turned it off.
So my question is, like in all the this risk assays like GWAS and all that, usually the population that they study is not like very like diverse in demographics. So I wanted to ask like whether like if you tested for these associations are in different demographics, they are still true, and whether we can use those associations for the drugs, drug selection?
That's a great question. And the short answer is this is not a diverse population. This is all Caucasian. One of the things that we struggle with in IBD is it's highly prevalent in Caucasian populations and less so in minorities. And so even in population cohorts, we get less sample sizes. And so there's a lot of good work coming out of like Miami, for example, where they're building great cohorts. And I think it would be nice to be able to say, okay, we're finding this. Let's look in additional cohorts that are more diverse and see if it holds true. So yeah, really great point, and I think something we need to think about.
Let's thank our speaker one more time.